Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea, Dean of the School of Public Health at Washington University in St. Louis and Editor-in-Chief of JAMA Health Forum. Today we discuss the nursing workforce in the United States and specifically a challenge to the prevailing notion that the country faces a national shortage of nurses. The US has more than 5 million actively licensed registered nurses. Nursing schools have roughly doubled their graduate output over the past 2 decades. And the total RN workforce has recovered from its pandemic-era contraction to levels close to what had been projected before the pandemic. Yet, hospitals continue to report high vacancy rates, nursing homes face chronic staffing crises, and burnout and turnover remain endemic. If we are producing more nurses than ever, why are so many patient care settings struggling to staff their units? The answer, increasingly supported by evidence, is that the US does not have a supply problem so much as a retention and working conditions problem. This distinction between a shortage of nurses and a failure to keep nurses at the bedside has direct and urgent implications for health policy and health services research. Here to discuss these issues is Dr. Linda Aiken, Professor of Nursing and Sociology at the University of Pennsylvania, where she directs the Center for Health Outcomes and Policy Research. Dr. Aiken is one of the most influential health services researchers of her generation. Her landmark studies, spanning more than 2 decades and conducted in the US and across more than 30 countries through the RN Forecast Research Program, have established a scientific evidence-based linking nurse staffing levels, nurse education, and the hospital work environment to patient mortality, safety, and quality of care. Her research has directly informed staffing legislation in California, Queensland, and several other jurisdictions, and has shaped international standards for nursing education. She is a member of National Academy of Medicine, a fellow of the American Academy of Nursing, and the recipient of the Claire Fagan Distinguished Researcher Award, among many other honors. I'm delighted to be speaking with her today. Dr. Aiken, welcome.
Thank you so much. I'm delighted to be here to talk about this very pressing topic.
So let's start with framing. So you've argued that the conventional wisdom that the US faces a national shortage of nurses is misleading. Nursing schools have dramatically increased their output. Total workforce has rebounded after the pandemic. So if the supply of nurses is not the central problem, how do we think about the nursing workforce challenge?
Well, the shortage of nurses in the country and the shortage of nursing care are two different things. The shortage of nursing care, which is what we're going to focus on primarily, is really the result of too few budgeted positions and high turnover. So when we say, why aren't there enough nurses at the hospital bedside or in nursing homes or in schools, it's that there are basically too few budgeted positions for nurses to elect to be employed in, and those that are employed tend to turn over because of poor working conditions.
Your research has consistently shown that nurse staffing levels are directly associated with patient outcomes. In your 2002 JAMA study, you found that each additional patient per nurse was associated with 7% increase in the odds of patient mortality. So how robust is this finding today? How has the evidence evolved over the past couple of decades?
Very robust. We've done multiple studies in the United States, different parts of the country. We've also done studies internationally. And quite interestingly, we get almost the same effect of nurse staffing on patient outcomes. And one of the things that gives us more confidence that this is really a causal relationship between nurse staffing and patient outcomes and not just an association that might be explained by something else is that we've started ourselves organizing interventions that actually change nurse staffing. And then we study them from the baseline to after they've been implemented. So we're able to show that if you actually improve nurse staffing, mortality decreases, sort of presenting the fact that this is a causal relationship. So this is what's evolved over time. We replicate it in many different settings, and we also see that it's associated with interventions that are directed to changing nurse staffing.
When I read your work, there's a lot of it that's quite compelling. And one of the most striking findings to my read is that staffing improvements only yield full benefits if there are good work environments. So in hospitals with poor work environments, adding more nurses has virtually no effect on mortality. So what does this tell us about the real leverage points for improving patient outcomes?
Well, the real leverage points are really improving the work environment. And interestingly enough, the American Hospital Association, really 20 years ago or so, published a major white paper with the title In Our Hands, which was a conclusion of people that were hospital experts that we could change this because we are in control of the work environments. We can change the way care is organized. We can change the degree to which clinicians, doctors, and nurses are engaged in decision making. And if we did that, and this is like back 20 years ago, we have evidence that things will be better. Unfortunately, the American Hospital Association hasn't really stayed on that agenda, but others have come in to show that that's the case. And a classic example is the magnet recognition program, that its total focus is improving the work environment. They've operationalized in a manual the steps to actually do this. So 10% of the hospitals in the US are magnet recognized. They have better work environments, and they have also better staffing as a result of more engagement of doctors and nurses in decision making and better patient outcomes.
Your RN forecast studies that I mentioned earlier, you've done this research in more than 30 countries. And in 2014, in The Lancet, you published across 9 European countries, and you found that both staffing ratios and the proportion of bachelor's prepared nurses were independently associated with hospital mortality. So, what have we learned from international comparisons that our domestic studies alone have not shown us?
When we published the original papers in JAMA in 2002, 2003, there were some skeptics, and they said, because it was a new idea, that nurses not only comforted patients and other things, but they were actually responsible whether they lived or not. Some skeptics said, oh, this has to do with the larger context of healthcare, particular US policies like the Balanced Budget Act and health maintenance organizations and such. And so we decided one way to refute that is to take this research and replicate it in other countries that had differently organized and financed healthcare systems, which would suggest whether this is a generic finding that is relevant in all countries, or maybe there's something in the background of US policy that is responsible for this. By replicating this in other countries, we found totally differently organized and financed healthcare systems, exactly the same outcome. And so that gave us much more influence, even within our own country, for groups to take action on our findings. And just to emphasize, one of the particular very important findings is on the education side, where our research was the first, as you say, to show that the greater the proportion of nurses with baccalaureate degrees, the lower the mortality. And as a result of that research in the US, which was also replicated internationally, nurse leaders started preferentially hiring nurses with bachelor's degrees. And then the National Academy of Medicine came in and recommended that the whole country move to at least 80% BSN nurses. Within 15 years, we went from 30% BSN nurses to almost 80% now. It was a huge impact of that research.
It must be gratifying to see work actually have that kind of impact.
Yes.
Let me move to COVID for a second, because I think part of the national narrative now, this is not the academic narrative, right, has been the pandemic was hard. Healthcare professionals, particularly nurses, left the workforce because of COVID. But in work from your center, including 2024 JAMA Network Open Study, the reasons that nurses left was planned retirement, burnout, insufficient staffing, issues that predated the pandemic. So, and this is, of course, consistent with everything you and I have been discussing. So why has this message been so difficult for hospital leadership and policymakers to absorb?
Policymakers are actually more open to trying to solve this. Policymakers, after all, are mostly elected officials of the public, and nurses have very high standing in the public. They're on the top of the Gallup poll of the occupations in which Americans have the most confidence. So, problem's not so much policymakers, but in hospital leadership, which advocates against certain policies that could perhaps address this problem. Now, why are hospital leaders so resistant? I think a couple of things. First of all, a major trend that's happening in our healthcare system, which we could talk more about, is the corporatization of healthcare, which means that our hospitals are in larger and larger systems, nursing homes as well, and the decision making moves further and further from the patient care nexus. And the decision making on resources for staffing and creating changes in the work environment are not even local anymore. And so that makes it very difficult to communicate to administrators that are making decisions the evidence base behind the need to make these changes and the business case that supports it.
When you think about what hospitals and health systems are doing to improve burnout, right? You have a lot of individual wellness and resilience programs. But when you look at surveys that you've done, right, both doctors and nurses say that improving nursing staffing is what really matters to address burnout. So that discrepancy, talk us through it.
Well, there is a big gap between leaders in hospitals, both nurse leaders and administrators, in assessing the adequacy of nurse staffing. We show this in our research that leaders assess staffing more favorably than their own nurses and doctors. So there's a difference in perception about whether staffing is good or not good. And that gap is something that we really need to solve and can solve. It's within our power to solve. But moreover, we find that in hospitals where physicians and nurses are engaged in decision making with money people and administrators, there is more of an understanding of the top management of the evidence base, but many hospitals don't have that. And so this is why we keep having the recommendation that we need to modernize the whole decision-making process in hospitals to flip it around somewhat, because now very top down, but all the clinicians are on the downside, and often in these big systems, they really have no voice anymore in even informing the decision makers about why they should make some of these decisions. There's not enough communication any longer between clinicians and people at the top that are not necessarily clinicians. They're making decisions about resource allocations and other policies.
So there were these really interesting, I think, natural experiments. California implementing mandatory nurse-to-patient ratio legislation about 2 decades ago, Queensland, Australia, following about a decade ago. And you've studied both these natural experiments. What do they tell us about whether legislative staffing standards actually work?
They tell us that legislative staffing standards do work, both in California and Australia. Very clear results published in major journals like The Lancet and JAMA. So the evidence is there that it works, no question about it. To give a statistic that we've looked at recently, the California law is over 20 years old. So from that one law passed 20 years ago, now the average patient in a hospital in California gets 3 more hours of RN care per day than a patient in hospitals in the other states. And this is because having these mandated minimum standards makes it possible for hospitals to stick with a high standard, even if external factors are going on, like, for example, the recession in 2008 or COVID in 2020. When we track, which we're doing, what's happening to staffing in California, what's happening in the other states, we find that you get a big risk factor from the outside, like COVID, and then hospital staffing drops off as hospitals try to cope. But in California, it doesn't drop. And so over time, it's the fact that when some external factor happens in the US, that it doesn't really allow hospital staffing to go down. And so over the 20-year period, California is really much superior in its staffing to the other states. So that's the powerful outcome measure.
Let's talk about something slightly different, which is, we talk about nurses and losing nurses in the workforce, but when many nurses leave bedside care, they don't leave the profession entirely. They move to telehealth, education, case management, other roles. How do you think about this redistribution of the nursing workforce? Is it a loss? Is it a natural evolution? How do we even factor it in when we're trying to think about adequate workforce?
Well, we've been studying that. It's not really clear that the hospital sector is losing nurses. There's a lot of turnover, but, our data suggests that most of the nurses that leave one hospital really go to another hospital. And so it's all of this throughput and disruption that results from people leaving and changing jobs. That's the major issue. Now, certainly some nurses are going to other jobs. And, my view on that is great because, nurses are adding value to healthcare in all kinds of different directions. And so it's great to have them wherever they are. But hospitals are not yet really totally losing nurses because really most new nurses want to go to hospitals as their first job because they think it'll give them the experience to build on over their career. So hospitals are still getting most new nurses and they're losing them. It'd be so much more difficult if they weren't coming to hospitals at all, but they are coming. And all of the evidence suggests that if hospitals could just focus on the evidence based interventions that have been shown to retain nurses, which is not offering a wellness officer, not offering quiet places and resilience therapy. The clinicians want hospitals to improve the work environment and the safety culture. That's what they really want. And that's what needs to be done. They're really hostile in many ways towards the sense that they should be more resilient. Doctors and nurses say, who is more resilient than us? We are resilient already, and these environments need to be changed to protect patients.
So when we're talking about changing the environment, we're talking about increasing nursing ratios. I don't want to have the conversation in a naive sense as though this existed in a vacuum from financial realities, right? So we are in a moment of fiscal pressure on the healthcare system. Nursing is one of the largest line items in operating budgets. You've shown that adequate staffing is a cost-saving investment. How strong is that economic argument, and why hasn't it been more persuasive? And how does one make it more persuasive?
It's a very strong economic argument. We have more and more research that shows that when you have an adequate number of professional nurses, you can reduce the length of hospital stay, which in the way we fund hospitals now is a great savings to hospitals that they could do other money with. So we show that millions of dollars could be saved by staffing appropriately to cut down even 1 day overall of hospital care saves multiple millions of dollars. In addition, we show that having adequate numbers of professional nurses significantly reduced readmissions within 30 days. And readmissions are very high. They're so high that Medicare is penalizing hospitals that have excess readmissions. So having the right number of nurses allows hospitals not to be penalized because they bring those readmissions down. And then the turnover costs are just so high. It's estimated that to replace a general nurse in a hospital is on average $65,000 and much more for a specialist nurse. Well, large hospital has 500 or 750 beds. If you have a 20% turnover, which is kind of where the numbers are these days, I mean, that is millions of dollars lost just through losing and replacing nurses. So we get back to, well, what do we do about it? And it gets back to, well, we need to change the work environment and we need to engage clinicians more in decision making.
Let's assume a couple of hospital leaders or people who are in position to affect change are listening to our conversation. What are 2 or 3 most important steps to stabilize nursing workforce and patient care that you would recommend?
Things that hospital leaders have control over would be to create a more formal structure of engagement of clinicians in decision making. That's been lost with all of these increase in the size and complexities of healthcare system. So that on average, decision makers that are making decisions about resource allocation and policies about the hospital are not even in the same room with or exchanging any information with clinicians at the bedside. So that has got to be fixed as a way to inform decision makers. I mean, after all, the product of healthcare is laying hands on people. That's what they're producing. And so if there's not very much understanding at the decision-making level of what that takes, that's kind of creates the problems that we have. So having what we call structural engagement of clinicians, having opportunities that don't depend upon one person at the top deciding, we'll listen to the doctors and nurses. So to have committee structure, to have what's called shared governance, where there's really an exchange of ideas between the expert clinicians in your organization and the people making decisions. There's a roadmap for doing that in the magnet program, and other programs as well. But there's a magnet manual that has step by step. How do you create this?
So let's end on a positive note. What gives you hope in the moment about future of nursing workforce?
Well, we have the largest and most well-educated workforce that we've ever had, and the largest and most educated in the whole world. The whole world is looking at us and what nurses have been able to do. And nurses have brought so many innovations in healthcare. I mean, they were in the front lines in COVID. They were among those that, developed pronation and all of these things that actually saved people's lives. But, we've kind of forgotten ICUs was a nursing idea. Patient and family maternity care, hospice. And we have so many examples that really came out of nursing. So they're very innovative. If we'd listened to them, we wouldn't have so many problems. I've kind of been amazed at how much money the hospital spent on consulting. This is one of the darndest things as far as clinicians are concerned. Hospitals are spending over $500 million annually on consulting when they have on their own staffs more clinician expertise than a consulting firm will ever have. So being more aware that you already have the experts, how about turning to them and let them have a role? On the policy side, I think there are 3 things that we could do that would very much help solve this problem of turnover. One is by setting minimum required standards for nursing. We have many standards in hospitals. We have no standards for nurse staffing. That would be one. Second, I think we need to make staffing more transparent. You can't find out what the staffing is at any hospital. There's no way to find it out. So we have a good Medicare website that's built for consumers called Hospital Compare and Nursing Home Compare. And on those websites, we should have auditable staffing so that you could go in and not only find out what's the patient satisfaction in the 2 hospitals you care about in your community, but what is their staffing? And third, we really need, with states, we need to standardize full practice authority for advanced practice nurses, which there's plenty of evidence would help us solve the shortage of primary care doctors. So those are my 3 things. Safe standards for nurse staffing, transparency in staffing in hospitals and nursing homes, and full practice authority for advanced practice nurses.
Well, that feels like a clear, perfect place on which to end. I'm Sandro Galea. I have been speaking with Dr. Linda Aiken about the nursing workforce and what it will take to keep nurses in patient care. Thank you for talking to us.
Thank you very much.
Follow us on JAMA Health Forum and the JAMA Network for more conversations on health policy. This episode was produced by Daniel Musisi at the JAMA Network. To hear this and other JAMA Network podcasts, visit us at jamanetworkaudio.com and jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.